assistant professor at Goenka University. I want to present on the topic Twincretin as a potential therapeutic approach for the management of cardiovascular risk. First of all, I would like to introduce cardiovascular risk, give a brief introduction of cardiovascular risk.
Nidhi, can you please zoom your presentation?
Associated with cardiovascular disease are all cardiovascular risk. Cardiovascular disease are a group of disorders of the heart and blood vessels commonly referred to as heart disease or stroke. The common cardiovascular disease are hypertension, myocardial infarction, congestive heart failure, angina, coronary artery disease, and atherosclerosis. These all are cardiovascular risk. Why there is a need for novel targets in the management of cardiovascular risk? Is there any need? Yes, there is need. Why? Because cardiovascular disease becomes the world's #1 killer. Around 17.8 millions of deaths every year occurs due to this cardiovascular disease, and 31% of the global deaths occur only due to this cardiovascular risk. And the global cause of death is also depicted in the graph. And CVD, that means cardiovascular disease, has the largest number of population, which is the sufferer of this global deaths. And the risk factors that are associated with cardiovascular risk are high blood pressure, high cholesterol, overweight and obesity, air pollution, physical inactivity, unhealthy diet, diabetes, tobacco consumption, kidney disease, and consumption of harmful use of alcohol also. So these all are the risk factors that are associated with cardiovascular disease. This is all about the prevalence, because every year 1 in 4 deaths occur due to this heart disease. This is also shown in this picture. The important risk factor, that is diabetes and hypertension, these two risk factors contribute to number of other risk factors, like in microvascular area, it causes risk of retinopathy. In heart, it causes congestive heart failure, coronary artery disease, and many more. And it may also cause strokes in brain, and in peripheral vascular system, it may cause diabetes mellitus. And even diabetes and hypertension, they both are interlinked to each other. 40 to 80% of diabetics have hypertension problem also, and diabetics 2 times likely to develop hypertension. So these two diseases are interlinked. If a person is diabetes, it may have more probability or more chances to develop hypertension also. So these two risk factors, if we can prevent, then we can also able to prevent or manage the cardiovascular risk. So there are many drugs or therapies which can target these two disorders side by side. So these are all risk factors for the cardiovascular disease. Like there are some preventable risk factors, like we can also say call them as modifiable risk factors, and non-preventable risk factor, that is non-modifiable. We cannot modify these because age is a factor which we can't do anything. If increased age can also leads to various types of disease, even cardiovascular disease also. Gender, we can't work on this. Race, ethnicity, family history, we can't work. But there are modifiable risk factors, or we can say that preventable risk factors, like type 2 diabetes. We can work on this. We can give anti-diabetic drugs, anti-diabetic therapy. High blood cholesterol, we can work on this. High blood pressure, we can work on this. Lack of physical activity, we can increase the exercise, yoga. These therapy also contribute in the management of cardiovascular risk. smoking cessation. If we quit smoking or cessation of smoking, uh, then it also helps in the management of cardiovascular risk. Overweight and obesity, it may also work, and unhealthy eating, because these all are risk factors. So we can work on this to prevent or manage our cardiovascular disease prevalence. Then come to my research topic, twincretin. Twincretin, what is twincretin? Actually, incretins are the group of metabolic hormones that stimulate a decrease in the blood glucose level. Basically, these are a group of hormones that decrease the level of glucose. That means they helps in the treatment of diabetes. They are incretins basically released after eating. After meal, they release and augment the secretion of insulin release, and they help in the release of insulin from our pancreatic beta cells of the islet of Langerhans by a blood glucose dependent mechanism. And what is twincretin? This is about incretin. Twincretin is a one molecule which has two incretin hormones. That means a molecule has two incretin groups, that is GLP-1 and GIP. What is GLP? GLP is glucagon-like peptide 1 hormone, and GIP is gastric inhibitory peptide receptors. These all are act in one drug, in one class. So twincretin is a unimolecular dual agonist of GLP-1 and GIP receptors. It is an innovative and powerful class for the management of diabetes. What is diabetes? Diabetes is the combination of diabetes and obesity. This particular class of the drug, twincretin, works on both diabetes as well as obesity, because these two are important or a common risk factor for the occurrence of cardiovascular risk. And tirzepatide is an FDA approved drug for this class. That means it works on diabetes as well as obesity. Now, my research work is on to uh, to evaluate or to elucidate the potentials of this particular drug in cardiovascular risk management also. This work is approved for diabetes and obesity, but our research is going on to elucidate or to evaluate the effects of this particular drug in the cardiovascular risk management. So these are some GLP-1 and GIP receptor agonists. Like GLP-1 receptors are exenatide, liraglutide. These are manufactured drug. They are already in market. Duraglutide, lixisenatide, semaglutide. These all are GLP-1 receptor agonists, and they are well approved, FDA approved drug for the management of diabetes. And dual incretin agonist, that means twincretin, we can say there is a drug tirzepatide. This drug has a good potentials in diabetes as well as obesity. This is just a brief of these three drugs: tirzepatide, semaglutide, and semaglutide. These are two different brands, and this tirzepatide is manufactured by Eli Lilly company, and the semaglutide is manufactured by Novo Nordisk. And this tirzepatide is manufactured in May 2022 only, and it is a subcutaneous injection which is given once weekly, and dose ranges 2.5 to 1.15 mg. It is a dual agonist. That means it's an agonist of GLP-1 as well as GIP receptor. And the common side effect with these drugs are nausea, diarrhea, constipation, and vomiting. That means they have GI side effects only. Average weight loss is this 22.5% of body weight after 72 weeks. So it has tremendous effects. Up now, this is all about diabetes and obesity. Now, what happens with this drug twincretin in case of cardiovascular risk management? Is it a novel target for the management of cardiovascular risk? Yes. Why? Because this picture or this table shows if we are synergizing the effect of these two receptors, that means GLP-1 and GIP, then there is a tremendous positive effects. There comes tremendous positive effects like HbA1c level comes very low, body weight also reduces, GI adverse events, there are GI adverse events also, and energy expenditure is increased, ectopic fat also decreases, and cardiovascular risk also decreases. These are GLP-1 agonist multiple effects, like it works on brain, it decreases appetite and increase satiety. Satiety is this satisfaction, and appetite is loss of craving hair and all things reduces. And in case of heart, it increases the myocardial contractility, that means it works in congestive heart failure, it decreases glucose uptake, and it increases ischemic preconditioning. And in case of blood vessels and microvessels, endothelial function cells increases, arterial stiffness decreases, inflammation decreases. And in case of kidney, it increases sodium excretion, it increases diuresis. So if sodium excretion increases, diuresis increases, so there is a control of in hypertension also. So BP also reduces, which is a good signal for the cardio protection. And in case of liver, liver fat decreases, inflammation decreases, insulin resistance decreases. Synergistic effects of incretins. So this is all about GLP-1. First column is of GLP-1, second is GIP, and third is the combination of GIP and GLP-1. So caloric intake decreases, GIP. So if we are taking Twincretins, which is a combination of both GLP-1 and GIP, so there is a synergistic effect, which is a good effect. Rationale of Twincretins in the management of diabetes. Diabetes, as already discussed, ki diabetes is the combination of diabetes and obesity. When we take the meal, K cells and L cells release GIP and GLP-1 simultaneously, and this GIP increase the satiety effect of GLP-1, decrease gastric acid secretion, increase insulin secretion, increase glucagon secretion, increase adipose deposition. And GLP-1, it increases satiety, it decreases gastric emptying. If there is decreased gastric emptying, so there is all satiety increases, that means satisfaction increases. So tendency of taking craving also reduces. So increase insulin secretion, decrease glucagon secretion. So these all two hormones, that means GIP and GLP-1, they have combined effect of reducing the weight, also the glucose. That means they have good effects, positive potential effects in reducing the body weight as well as glucose levels. So they are helpful in the management of diabetes as well as obesity. So this is the mechanism of action of Twincretin therapy. If Twincretin, that means drug which is having both the hormones like GLP-1 and GIP-1, it is taken, then pancreatic islet will it has two cells, alpha cells and beta cells. This alpha cell decreases or blocks the release of glucagon, and beta cell increase or stimulate the release of insulin. If insulin level stimulates, so glucose level automatically decrease, and this glucagon is responsible for increased glucose level, so this also diminishes through the alpha cycle blockage, alpha cell blockage. So overall effect is decrease hyperglycemia and increase insulin sensitivity. So thus it has a surpassing expectation effects on the diabetes and obesity. Then tirzepatide, which is a Twincretin therapy. Is it a miracle or a curse? No, it's a miracle because it is a remedy for various illnesses. Like in this picture, I have clearly mentioned tirzepatide. It works on brain, it works on pancreas, it works on white adipose tissue. It works on brain, then it decreases appetite, it decreases food intake and increase weight loss. And in pancreas, it increase insulin secretion, insulin synthesis, and beta cell survival. And in white adipose tissue, it increases lipolysis, that means breakdown of lipids. So lipid level also decreases. The lipogenesis also increases and avoid ectopic fat deposition. That means deposition of ectopic fat also reduces. So it has beneficiary effects in obesity as well as diabetes. These are some insights of tirzepatide in various fields like beta cell functions. It enhances the first phase insulin secretion. Thus, GIP potentiate insulin secretion in response to weight loss. में tirzepatide decreases food intake and appetite. It increases energy expenditure. If energy expenditure increases, so also weight loss occur. GIP modulates GLP-1 induced weight loss and nausea. And it also works on insulin sensitivity. That means it improves the insulin sensitivity. It makes the insulin more sensitive. It works greatly. And in cardiovascular system, it improves lipoproteins and vascular inflammation. It reduces vascular inflammation, and thus it has beneficiary effects in cardiovascular system also. And in adipose tissue, it enhances free fatty acids and improves metabolic flexibility. These are the rationale of tirzepatide in cardiovascular risk management, which is our main topic. This diagram, this picture depicts there is K cells and L cells which are present in our GIT and liver. These K cells and L cells exhibit the response of GIP and GLP-1, and this GIP and GLP-1, they further decrease fasting glucose level, decrease weight, decrease triglyceride levels and lipoproteins, decrease dose-dependent lipid profiles, decrease BP, decrease albuminuria, increase insulin secretion, increase insulin sensitivity, decrease gastric emptying, hunger. So that means it has overall effect as it decreases cardiovascular disease, it decreases PAD, that means peripheral arterial disease and cardiovascular disease also, and also reduces the progression of CKD, chronic kidney disease. So ultimate effect is cardiovascular risk management. So potential mechanism of tirzepatide, these are all cardiovascular benefits. Like if glucose level decreases, ultimately cardiovascular risk decreases, because if there is a control on diabetes, so ultimately it also results in decreased cardiovascular risk. If there is decreased body weight, that means obesity decreases, obesity problem solves, then also cardiovascular risk manages. If BP reduces, because these all are in first slide, in previous slide, I have mentioned these are risk factor. If we work on risk factor, so ultimately effect is we can manage cardiovascular risk. So that means these all contributing factor leads to the protection of cardiovascular. That means it protects our heart. It decreases inflammation. It decreases dyslipidemia. That means lipid profile. It manages our body weight. It manages diabetes. It manages hypertension and also inflammation. So these all have cardiovascular protective effect. So my conclusion is tirzepatide is a unique dual receptor agonist of both GLP-1 and GIP receptor. Significantly reduces HbA1c level. That means it controls diabetes as well as it reduces the body weight. So it is given once weekly dosing, and it has potential cardiovascular benefits, which makes it an attractive option for treating these conditions, because these triple disease occur goes in hand. They are occur simultaneously. Tirzepatide ability to co-administer GIP and GLP-1 has synergistic effect on reducing body weight, food consumption, and fat mass. So this drug, why this drug is unique? Because this particular drug is controlling three problems, managing three problems: diabetes, obesity, as well as cardiovascular risk. It manages three important problems. So although they have some GIT symptoms, like I have mentioned, they have nausea, vomiting, these all are mild to moderate, and future research is needed to understand the long-term effect of this drug on the cardiovascular outcomes. Thank you.
Practices regarding newborn care. The objective of my study is to bring forth a thick description of the cultural aspects of newborn care in a researcher-interested population and identify cultural themes related to the newborn care, which will help the health professionals to understand and tailor interventions in the healthcare setting. So, introduction and the need for the study. The days and weeks following childbirth, the postnatal period, are a very critical phase in the lives of the mothers and newborn babies. So, according to WHO in 2015, 45% of under 5 deaths occur during the first month of life, and several factors contributed to the mortality. And one of the reasons following harmful practices such as inadequate cord care, discarding colostrum, and feeding other foods. So, as cultural beliefs and practices play a very important role in the care of the newborns, the nurses should be striving hard to provide culturally sensitive care, which can increase the client response and compliance. So, hence, the investigator would like to explore the cultural and traditional beliefs related to newborn care and promote cultural sensitive care by the nurses so that appropriate educational messages can be transferred to the patients, the relatives, as well as the caretakers of the newborn. So the methodology, I have used a qualitative research design. It is a focus ethnographic study. As we all know, ethnographic studies focus on the cultural and beliefs of phenomena. Here I have put it as focus ethnographic study because I'm mainly focusing on the cultural beliefs and practices of newborn care in South India. So that is why it is put it as a focus ethnographic study. And the setting was maternity wards of Christian Medical College, Vellore. The samples were the mothers, grandmothers, and the relatives who fulfill the inclusion criteria. And the sample size was 8 to 10 members. After that, I achieved the data saturation. So I didn't go beyond 8 to 10 members. And the sampling technique was a purposive convenience sampling technique. The inclusion criteria, the grandmothers and other relatives who have already had an experience of taking care of the newborn, the mothers who have taken care of at least one newborn, that means the second time or third time she's mother now, and the mothers who are in the second postnatal day, and mothers who comprehend and speak English or Tamil. Exclusion criteria, mothers whose babies are admitted in the neonatal unit and mothers who are sick during the postnatal. The instrument, I took two instruments, part 1 and 2. The part 1 was demographic variable, which included the type of the family, the religion, the education, and the parenting. And the part 2 was a semi-structured questionnaire because as the mothers were not able to talk fluently or continuously, I used probing questions on breastfeeding, cord care, bathing, evil eyes, and so many other things so that they can give up the answer or continue with the talking. Data collection. The data in the study was gathered through 3 focus group discussion, which included the mothers, the grandmothers, and the other relatives. And a semi-structured questionnaire was used to elicit the participants' emic and ethic perspectives on the practices related to the newborn care. And each focus group contained 8 to 10 members who was included after obtaining an informed consent, and the interviews were audio recorded. Data analysis. Data from the translated interviews was coded and categorized to identify the cultural themes. A thick description of the cultural aspect of newborn care was presented as a research report, which is as follows. So the results, I had various themes, and the first theme was traditional beliefs and practices. So the 3 focus group people, like mothers, the grandmothers, and the relatives, they came up with various beliefs and practices like ritual bath. They said 9th day of the birth, a ritual bath will be given for the baby, and the bathing was done with the hot water. And before giving bath with the hot water, oil must be given. And the cord care, they said they will apply coconut oil if the area is raw. And they also said that breastfeeding is the best food for the baby for 6 months and better immunity, which was really amazing to listen, because till now, there were many concerns from the community side telling that breastfeeding as well as additional food should be started, because breastfeeding alone is not enough. But then I was amazed to hear from them that everybody accepted that breastfeeding is the best for the baby. And they also came up with some pre-lactal feeds like sugar water or honey water given for the newborn baby, because they said they wanted to start the life of the newborn with happiness, and they want the baby to be happy throughout the life. So they started with the sugar or water or honey water. And then additional feeds like warm water or gripe water is given if the baby is presenting with abdominal pain. And they also said about evil eyes. They will take alum or apply kajal on the baby's eyes, or they will wear black bangles. All this prevented evil eyes. And they will also they will not take the baby after 6 p.m. outside the house. So, sharing all these traditional beliefs and practices, they also accepted that though they are following, or though their elders were following all these traditional beliefs and practices, because of the institutional deliveries and because of the influence of the health professionals and the media, so all these traditional practices were slowly coming down, and they started to seek for health. Health seeking behavior was found in the people. They take the babies, they said they will take the babies immediately to the hospital. They will not go for any traditional treatments. Immediate seeking for health was identified from the group. But though they were identifying for health or seeking health behavior was found among the people. There were also some group of people who wanted to come to hospital immediately if there is any health need. They were trying to follow the traditional practices. So especially the mothers were expressing that we are ignorant about the newborn care. We don't know how to take care of the newborn baby. We always wanted to depend on the elders. So they said, because we have to depend on the elders, we have to listen whatever they're telling us to follow, like the traditional practices. And they also had the fear of blame, like what if something happens. Suppose the women wanted to follow and though what is taught in the hospital, and she doesn't want to follow the traditional behavior, and something happens to the baby, and that fear of blame was there in women. So she wanted to give the responsibility to the elders who wanted to follow the traditional practices. And they also had the family pressure. If the woman is against the traditional practices and she wanted to go to the hospital, if there is a health need for the newborn baby, there will be some problems or fights in the, especially with the in-laws husband. So because of the family pressure, they don't wanted to change, and they were still holding on to the traditional practices. um, And when we were discussing with the group, and finally they came out with the last theme, that was problem solving. The best solution for all this thing is family centered teaching, where the husband and the mother-in-law should be included in the teaching, so that they can be able to follow whatever is being taught in the hospital. So these were my themes and sub-themes, and the nursing implication from my study. I identified that the qualitative from the study will bring forth meanings underlying the practices and beliefs related to the newborn care, and it also helped in increasing the cultural sensitiveness and assisted in delivering appropriate education messages to the patients, the relatives, and the caretakers of the newborn. So, as I would like to conclude by telling that most of the harmful traditional practices followed in olden days are stopped due to the increased facilitation of hospitals. Education also plays a very important role in which people do not want to follow harmful practices and take the babies to the hospital if there is any problem. But there are few people who still follow of the harmful practices, which need to be known by the nurses taking care of the newborn, so that culturally sensitive care and teaching can be given to enhance better compliance of the caretakers of the baby. Thank you.
Thank you very much, madam. Thank you for your valuable presentation.
Untitled Immune-mediated inflammatory diseases diagnosed in internal medicine department at the University Hospital Center of the Point G, an epidemiological and clinical overview. I'm Dr. Keita Kali from Mali in West Africa. So what is a human-mediated inflammatory disease? They are characterized by dysregulation of the normal human response, which leads to inflammation. Also, it is characterized by three nosological entities and their nosological sub-entities. First, we have autoimmune disease, subdivided into systemic autoimmune diseases, organ-specific autoimmune diseases, and secondly, we have autoinflammatory diseases subdivided into two subgroups, monogenic autoinflammatory diseases and polygenic autoinflammatory diseases. Based on their clinical feature for polygenic autoinflammatory diseases, we have two subgroups. That is the systemic polygenic autoinflammatory diseases and organ-specific polygenic autoinflammatory diseases. That is a novelty. Thirdly, we have inflammatory disease of undetermined mechanism. We have three sub-entities: neoplasm, paraneoplastic syndrome, and inflammatory diseases of iatrogenic origin. What is known about the epidemiology of immune-mediated inflammatory diseases? The prevalence of immune-mediated inflammatory diseases in Western society was estimated to from 5 to 7%. Immune-mediated inflammatory diseases patients represented 4% of the population according to US healthcare datasets. Another American study revealed the overall prevalence of some selected immune-mediated inflammatory represented 2,258% per 100,000 inhabitants. The contrast is that the African literature seems to be on the fringes of this new concept in rheumatology. But epidemiological aspect of some nosological entities and subnosological entities of immune-mediated inflammatories have been reported, such connective tissue diseases, autoinflammatory diseases, and neoplasm. But there were no study addressing together all the three nosological entities of immune-mediated inflammatory disease in Africa. The mechanism, pathophysiological mechanism of immune-mediated, many literature data conclude that these nosological groups have in common the inflammatory pathway, but their clinical and biological expression are extremely diverse. What about immunogenetic of immune-mediated inflammatory disease? Many evidence demonstrate the role of the major histocompatibility complex in the susceptibility to certain immune-mediated inflammatory diseases such multiple sclerosis, diabetes type 1, rheumatoid arthritis, Crohn's disease. Understanding the genetic risk and extent of genetic overlaps between immune-mediated inflammatory disease may contribute to determine which genes control which aspect of the different disease. Environmental factors are essential components of the pathogenesis of immune-mediated inflammatory disease, and they are known to be responsible for their growing incidence in the world. Epidemiological, clinical, and experimental evidence supports an association between immune-mediated inflammatory disease and a large number of seemingly unrelated environmental factors, including smoking, diet, drugs, geographical and social status, stress, and microbial agents. In addition, the endocrine disrupting chemicals and emerging environmental factors, they exist widely in our life. They are associated with many diseases. They are coming from food packaging, soil, plastic, pesticides, etc. For example, bisphenol A, etc. So the epidemiological transition about immune-mediated inflammatory disease in developing countries. It is important to know that we are witnessing an economic advancement, the adoption of Western lifestyle and of dietary habits characterized by higher intake of meat, fat, total calories along with increasing life expectancy and population growth. Plus the genetic and a large number of environmental factors. This evidence demonstrates the need to well appreciate the trend of epidemiology of immune-mediated inflammatory disease. The central hypothesis is that the panoramic study of immune-mediated inflammatory disease will contribute to identify similar and different epidemiological, clinical, immunogenical, environmental, and pathophysiological features. Immune-mediated inflammatory disease sharing similar features could direct research of the same therapeutic targets and new approaches for preventive medicine. We aimed in this present work to describe immunological and clinical aspects of all immune-mediated inflammatory diseases diagnosed in internal medicine department at the University Hospital Center of the Pointe-G. We conducted a descriptive study with a retrospective data collection on medical records of patients hospitalized for immune-mediated inflammatory diseases in the Department of Internal Medicine at the University Center of the Pointe-G for a study period of 2 years from January 1st, 2018 to December 31st, 2019. This was an exhaustive sampling of all cases of immune-mediated inflammatory diseases during the study period. The diagnosis of immune-mediated inflammatory diseases were made based on clinical and paraclinical data and or validated diagnosis criteria according to the type of immune-mediated inflammatory diseases. For data collection, we used pre-established survey form, including epidemiological and clinical characteristics. Data entry and analysis were done using SPSS version 2022 software. The results. This figure showed the overall distribution of patients according to the immune-mediated inflammatory diseases. 921 patients were hospitalized. 205 patients presented immune-mediated inflammatory diseases. Among them, 2 patients presented an association between 2 entities of immune-mediated inflammatory diseases, which is a total of 205 cases, and which is efficacy hospital of 22.48%. The immune-mediated inflammatory diseases were dominated by inflammatory diseases of undetermined mechanism, with 113 cases, followed by autoimmune disease with 84 cases, and finally by autoinflammatory diseases with 10 cases. Note here, we found no cases of monogenic form and 10 cases for polygenic forms. The inflammatory diseases of undetermined mechanism were dominated by neoplasm with 109 cases, followed by paraneoplastic syndrome and inflammatory disease of iatrogenic origin with 2 cases each. The inflammatory autoimmune disease were dominated by organ-specific autoimmune disease with 72 cases versus systemic autoimmune disease with 12 cases. And note here, organ-specific autoimmune disease include type 1 diabetes. The autoinflammatory polygenic form were dominated by organ-specific polygenic form with 7 cases versus systemic form with 3 cases. This table describes the distribution of patients by sociodemographic data. 56.10% were female in our study. The age group of 20 to 39 years represented 30.54%, and house worker represented 22%. 71.22% of our patients were urban residents. This table shows the distribution of patients by autoimmune disease. The autoimmune disease were dominated by organ-specific autoimmune disease. The type 1 diabetes were the most represented among them with 55.56%, followed by Brothers disease, autoimmune hemolytic anemia, Diabetes disease, autoimmune polyendocrinopathy, etc. And the systemic autoimmune disease were dominated by rheumatoid arthritis with 33.33%, followed by systemic lupus erythematosus and systemic scleroderma dermatopolymyositis, SARP syndrome, and Quisrat and Sjogren syndrome. Here we have the distribution of patients by autoinflammatory disease. The inflammatory disease were dominated by polygenic autoinflammatory disease. We found no cases of monogenic form. The polygenic form were dominated by organ-specific polygenic autoinflammatory disease with 7 cases. They include 4 cases of chronic inflammatory rheumatism and chronic inflammatory bowel diseases. And the more prevalent were good with 28.57% and ulcerative colitis. The systemic polygenic autoinflammatory disease, we found heart disease, systemic sarcoidosis, still disease, 1 case each. We have in this table the distribution of patients by inflammatory disease of undetermined mechanism. The inflammatory disease of undetermined mechanism were dominated by neoplasm. Among them, tumor solid were more prevalent with 77 cases versus hematological malignancy with 31 cases. The hepatocellular carcinoma was the more represented among solid tumor with 18.18%, followed by breast cancer, stomach cancer, prostate cancer, etc. And the malignant hematological malignancy were dominated by non-Hodgkin lymphoma with 45.16%. The neoplasm were followed by paraneoplastic syndrome. These include paraneoplastic arthritis, paraneoplastic lower limb thrombophlebitis, 1 case each, and finally, inflammatory disease of iatrogenic origin, 2 cases. They include pyrazinamide-induced gout and dexamethasone-induced fragility osteopathy, 1 case each. Out of the 40 cases of type 1 diabetes, we have a distribution according to the age group. The age group of 25 to 44 years represented 52.5% in our series. 65% were female. Common ethnic group represented 27.5% in our study. And 72.5% of our patients, diabetes type 1 patients, were urban residents. In conclusion, immune-mediated inflammatory diseases are frequently diagnosed in internal medicine and characterized by their frequent occurrence in women, and preferably between 20 and 39 years of age. Immune-mediated inflammatory diseases are dominated by inflammatory diseases of undetermined mechanism, followed by autoimmune diseases and autoinflammatory diseases. The organ-specific autoimmune diseases are more prevalent than systemic autoimmune diseases. The type 1 diabetes is the most represented among specific autoimmune diseases. That is the reference. Thank you for your attention.
Thank you very much, Dr. Keta. It was interesting.
Kinshasa is the capital of Congo. The Democratic Republic of the Congo is one of the poorest countries in the world. The population is plagued by tropical infections and poverty-related diseases. The Greek Orthodox Christian Church has established a health center in order to meet the population health needs in a rural district of Kinshasa. Description of the health center of Kinshasa. The health center of Kinshasa.
Sorry to interrupt you, Michael. Can't you make your camera to your face because we can see your
Oh, yeah, sorry.
face? But yeah, that's great. No, it's okay. Thank you. Thank you. Sorry
Sorry.
to just stop you.
No, the health center of Kinshasa. The name of the health center is Panagia Soumela and Saint Panteleimon. Has the characteristics of a rural health center because it is located in a densely populated area of the capital of the Republic of the Congo. Health Center of Kinshasa, Panagia Soumela, and Saint Panteleimon will cover part of the population of the region of Mongafula, it's a commune of Kinshasa. We need to know which other health centers exist in the area, as well as which is the nearest hospital that provides secondary care services in the area to which we can refer. It will be useful to know the geographical boundaries of the area of responsibility of the Kinshasa municipality, as well as the exact number of inhabitants of this area. This can be seen at the chapter 7S4 that follows with an image. The archive of Health Center of Kinshasa will be created by recording in it all the inhabitants of the area of responsibility in cards similar to those used by other health centers in Kinshasa. It will be even better if the existence of software was foreseen so that the data of the patients will be recorded electronically. This will help in the better management of the data of the patients of the health of Kinshasa, especially useful for the remote processing of the data, which will be done by the team of doctors of Greece and other countries, etc. More on technological analysis of the external environment. This is the 7S analysis. What I'm presenting to you is the 7S analysis. We have done the best SWOT analysis. I am about the technological, I am referring to the PEST analysis. Objective of these studies is to analyze the internal framework of the health center before deployment. The concept of an urban primary healthcare centers already implemented in some European countries, such as Greece, was used as a method. I'm talking about the methodology of this my presentation. This concept was subsequently adapted in the local context. Quality of care and accessibility of the services provided were at the heart of this planning. 7S analysis is a useful tool that highlights the organizational design based on the 7 key internal elements: strategy, structure, system, shared values, style, staff, and skills. Analysis emphasizes the interaction between the 7 elements as a prerequisite for effective operation of our health center. And we start our analysis with first S, which is strategy. The problems and weaknesses in defining the PES and SWOT analysis must be taken into account in the formulation of the strategy of the Health Center of Kinshasa. This will consist mainly in the improvement of the health services provided through the Health Balance Scorecard tool. Health Balance Scorecard is a tool of quality. My second presentation, which is in the end of this section, is has to do to implement a European model in Kinshasa. I will show you what is the Greek law about the primary health care. So with the law number for 4486 of 2017, with this reform of primary health care, urgent regulation under the Ministry of Greek Health and other provisions. There is a definition of the primary health care. What is primary health care? Is the general system of providing outpatient health care services which ensures equal access of the entire population at individual and family level to primary healthcare services. This system aims to prevent, maintain, promote, restore, and strengthen the health of all citizens by providing certified medical services, examination and medicines, and the adoption of common rules of primary care and prevention for public health. And then there are defined the side goals of the primary health care means all integrated services within the national health system, which aim to monitor, maintain, and improve human health. Services include health promotion, disease prevention, diagnosis, treatment, comprehensive care, and follow-up. The state is responsible for providing quality primary health care services to the whole population with respect for its rights and needs. The services of primary health care include A. Health services for the provision of which the admission of the person to a hospital unit is not required. B. The assessment of citizens' health needs. The design and implementation of measures and programs for the prevention of diseases, the universal implementation of national screening program for selected diseases, and the promotion of health. C. The management of patients with chronic diseases. D. The reproductive health and mother and child care. E. Referral follow-up and, where appropriate, co-management of cases with secondary and tertiary care. F. The provision of emergency pre-hospital care. G. The implementation of vaccination programs. H. Physiotherapy services, the provision of palliative and palliative care, the provision of primary mental health services and the interconnection with mental health and addiction treatment services, primary dental and orthodontic care with emphasis on prevention, liaison with social care services, liaison with public health services, occupational health and safety services in cooperation with the relevant bodies as appropriate. K. Home health care and home care. 3. The services of primary health care are organized and operated in accordance with the principles of free universal health coverage of the population, equal access to the health services, special care for vulnerable social group, ensuring the quality and safety of services provided, continuity of health care, the responsibility and accountability of healthcare providers, the ethics of the medical profession or any other health profession, the proximity of services at the places of residence or work, the connection with other health services, the national referral to other units or services of the national health system. We talk about Greece, but now we will talk about Kinshasa. Or conducted providers for diagnosis, treatment, hospitalization, or further care. cross-sectoral cooperation with local, social, and scientific bodies, as well as community health education and its active participation in meeting its health needs. We are going to find the corresponding legislation of the Ministry of Health of the Republic of Congo, which refers to the primary and secondary goals for the Health Center of Kinshasa. And we made a combination, what we do here in Europe and what they ask the authorities there. The Kinshasa Health Center will belong to the Greek Orthodox Church of Kinshasa and will be chaired by His Eminence the Metropolitan of Kinshasa, Mr. Theodosios. According to the referred above in the definition, primary strategic goals of the care of Kinshasa are prevention, maintenance, promotion, restoration, and strengthening of the health of all citizens by providing certified medical services, examinations, and medicines for the residents of the area of responsibility of Kinshasa. Key actions to achieve these goals are: 1. The holistic treatment of the patient as a psychosomatic entity and the management of chronic diseases with the help of a follow-up file. This presupposes the existence of a well-organized file, storage of patients' files, the existence of an appointment system, and the implementation of the institution of the family doctor, which as I will show later, family doctor is in Kinshasa, is the main doctor in Kinshasa. The creation of a well-organized system of referral to specialists, and cooperation with them for the treatment of chronic diseases. Preventing activities that are mainly the investigations of risk factors for cardiovascular diseases and their treatment with the operation of a diabetic and anti-hypertensive clinic, etc. Anti-smoking campaign in the schools of the area and an effort to operate a clinical smoking cessation in collaboration with the Hellenic Anti-Smoking Society. Also, the application of the existing laws of the Ministry of Health of Congo, the Democratic Republic of Congo, or prohibition in public and other spaces, starting from the prohibition of smoking. Starting from the Health Center of Kinshasa. The anti-smoking effort is a prevention both for cardiovascular diseases and for cancer in general, but mainly the lung cancer, because it is the main preventable factor. Health education for the residents of the area of prevention issues in the most common diseases of Kinshasa, carrying out a test up in the female population of the area for the ages over 20 years, following the guidelines of the Democratic Republic of Congo. The vaccination of the children of the area. To the above will be added the current prevalence of diseases in the area of responsibility of the Kinshasa municipality, because there are other diseases that do not exist in Greece. So we must take in consideration the most common diseases which are in Kinshasa that we don't have in Greece, in Europe. This will result from the impact of disease in the area. A relevant study has been done on the cases examined by the first Greek mission operation of a doctor's office and Orthodox University of Congo. There is studies more of the Health National Organization, but we have started a small study by ourselves when we do a 3 weeks visit 2 years ago, a medical team, and we examine patients in Mongafula, and these are the results, the prevalence. So the main diseases diagnosed in 437 patients who were examined were malaria, 95%, gastrointestinal infection, 14.6%, The reasons why the inhabitants of Mongafula seek medical help are mainly fever that persists and persists in the area. The most common pathological cases that could be helped by the possibility of hospitalization are mainly severe forms of malaria and persistent diarrhea, complicated complications, which are dehydration, electrolyte imbalance, etc. This is the first study that we must do more studies to see what are the most common diseases in our area and do the relevant prevention. Now, the second S is staff. So we must analyze this topic. The Kinshasa Health Center will belong to the Greek Orthodox Diocese of Kinshasa, as already said, and it will be chaired by His Eminence Metropolitan of Kinshasa Theodosios. In a personal communication we had with the late former Metropolitan of Kinshasa, Mr. Nikiforos, he had also testified the following regarding the way of administration and supervision of Health Center of Kinshasa, Panagia Soumela, Agios Panteleimon. He stated in a contact we had, the steering committee of the center to consist of a committee of doctors from Greece, so that it is not influenced by local interests of Kinshasa. His Eminence Archbishop of Kinshasa will have the highest stewardship, but the decisions on the recruitment of staff and other decisions will be made by the committee, which will be in Greece. According to this, already we have has been established the Kinshasa Health Center Research and Quality network. The result of this team is what I am presenting. We continue with staff S2 from the experience of the members of Health Center of Kinshasa during the exploratory visit made by order of the late former Kinshasa. In order to determine the way that other health centers of the area operated, the following was found. The health centers of primary care units of the area employees almost exclusively general practitioners. All other specialties are absent. They have a rudimentary equipped biopathological laboratory. There is only the possibility for ultrasound. There is no possibility even for simple X-ray. These centers are also used as maternity wards where the locals come for childbirth. However, there is no equipment for dealing with complications or neonatal problems. From the above, we can determine the minimum staff needed to start each operation, the health center, without lagging behind the existing similar health centers in operation of the area. We can hire one generalist, one nurse, one administrative. If the economic we can afford the nurse, we also do administrative duties and the cleaner. Now, the other S is financing. In first analysis, in the economical dimension, a more detailed analysis is developed. In first analysis, which I said before, is another analysis that we have done, we talk in detail about this financing, which is the most important item in order to start working the health center. Referrals. In Kinshasa, there are many hospitals, but there are only a few ones close to Mongafula commune. As seen in the map below, I will show you, the closest health facilities are the University Hospital, Clinic Universitaire de Kinshasa, the Hospital Center of Mongol, the Fokam Health Center. The first two seem to be sufficiently equipped and might be useful for patients who need further referral. So we have closed a hospital. We can refer our patients. We should be in contact with them and obtain detailed price lists for the different services they provide. In the same about referrals, Hospital Center Mongkol is a 160-bed hospital and seems to be related to the Catholic Church as Opus Dei supported its construction. The University Hospital is located next to the campus of the Faculty of Medicine of the University of Kinshasa. There are internal medicine, pediatric surgery, obstetric gynecology, tropical medicine, dental stomatology departments. In addition, they have a COVID treatment center with 42 beds, of which 5 are critical care beds. Both hospitals are open for 24 hours, 7 days a week. In according to WHO report, there is also a 22-bed public hospital in the area. This is here is the map of the region in Mongafula with the health units I told before. Training. It's S4. It's the treatment of S4. The training. The training of employees, we must consider the training of the employee of the center will be carried out on the model of the corresponding training of primary healthcare professionals which take place in European health centers. Assessment. The assessment of health professionals will be done with health balance scorecard. In my second presentation, I will have the opportunity to present you what is this health balance scorecard I'm talking about. This will be a tool for the assessment, which is one of S. Skills. The appropriate skills needed to address the health problems of the region will be developed. It will describe, sorry, there is, no, it's an S. 6S is the style. It will describe the style of practice of medical practice used by the other health professionals from the health centers of the region who know the local complexes. Local healers and traditional doctors are widely used for advice and treatment in Africa. These are long, deep-rooted traditions and still very popular as they are many address health needs. For example, due to increased costs or inadequate accessibility of healthcare, due to increased costs and inadequate accessibility, the people use these healers, local healers. Care should be taken not to exclude completely or attempt to fight their usefulness for the population. E.g., they could be used complementary in palliative terminal care when not many options are available, but rather clarify to the patients that in some serious medical cases, local healers may lead to delays in seeking appropriate treatment or that there is a risk of poisoning, toxicity with some plant. The 7S is cultural environment. The cultural environment of the residents of the area of Kinshasa should be submitted. This will be helped by local health professionals who are more familiar with local conditions than us. So when we start working, we will we will develop this section 7S. A conclusion: 7S analysis, which is used at European primary healthcare units, seems to be very useful in the effort to organize a primary healthcare in Kinshasa, Republic of Congo. Here is some photos of this care center. You can see some outside. You can see around there are local inhabitants, local they live local inhabitants, local people. Outside, inside you, inside the stairs, there is two roofs. another review. Thank you very much for your attention.
Thank you. Thank you very much, Dr. Michael. It was interesting and it was informative. So without wasting the time, I would like to request you for your next presentation. That is implementation of health balance to display full screen, so it will be easy for the participants.
Just right now.
Yeah, thank you. Sorry for disturbance.
No. Okay.
Yeah, that's great. Thank you.
Okay. Results and of course short conclusions. What is gestational diabetes? It is the most frequent complication of pregnancy. The pathogenesis of gestational diabetes is considered to involve beta cell dysfunction and insulin resistance. It is associated with a significant risk of macrosomia, in addition to a high probability of metabolic complications for the offspring. Unfortunately, the precise mechanism underlying gestational diabetes is still unclear. International Federation of Gynecology and Obstetrics recommends that hyperglycemia and gestational diabetes should be considered a global health priority. Why? Because the prevalence of gestational diabetes has been reported to be at 20% of all pregnancies worldwide, but it is increasing due to the epidemic nature of obesity among women during reproductive age. In the diagram, we see the prevalence in different countries. And many data shows that everywhere the gestational diabetes is increasing. Other data shows that 1 in 6 live births occur to women with some form of hyperglycemia. 84% of them are due to gestational diabetes. Unfortunately, hyperglycemia and gestational diabetes is associated with maternal mortality, maternal morbidity, perinatal and neonatal morbidity, and long-term consequences, complications for both mother and child. So we discussed gestational diabetes leads to metabolic syndrome, type 2 diabetes, and obesity for child, and obesity and perimetabolic syndrome during childhood. In physiopathology of gestational diabetes occur different changes. We discussed about an increased level of leptin, ghrelin, estrogen, cortisol, progesterone, show a lower level of adiponectin. All of these changes lead to a lower level of insulin, hyperlipidemia, and a high level of insulin resistance and hyperglycemia. All of these changes lead to also to changes of placental transport of glucose, amino acids, and lipids. So in the offspring occur gluconeogenesis, lipogenesis, excessive anabolism, hyperglycemia by fetal pancreas stimulation, which leads to hyperinsulinemia, and in the end, low level of leptin and ghrelin, and higher levels of adiponectin, insulin, and C-peptide. Beta cell dysfunction and insulin resistance are the most important factors in gestational diabetes. Insulin resistance aggravates beta cell dysfunction by excessively stimulating insulin production in response to hypoglycemia. So this mechanism is known to be glucotoxicity, which leads to a vicious cycle of hypoglycemia and insulin resistance, and eventually beta cell apoptosis. Malfunction of beta cells can typically appear at different levels. We discussed about proinsulin synthesis or post-translational modifications, defects in secretory vesicle storage and exocytosis, or sensing of blood glucose concentrations. In response to insulin resistance, pancreatic beta cell functions is affected, which leads to an increased level of both intact or split forms of proinsulin. Physiological insulin resistance during pregnancy is necessary for fetal growth, but in gestational diabetes appear an excessively insulin resistance and hyperglycemia. There are other factors involved in physiopathology of gestational diabetes. We refer to adipocytes like leptin and adiponectin. So the adiponectin is an adipocyte which regulates insulin action and glucose homeostasis, and its level decreased during pregnancy. During the third trimester of pregnancy, the severity of maternal insulin resistance is higher, and circulating adiponectin is lower. Hypoadiponectinemia during pregnancy has several effects, which leads to increases insulin resistance in skeletal muscle, reduced glucose uptake, increased pancreatic beta cell dysfunction, and induce hyperglycemia. There are several data that show that maternal adiponectin was found to be higher in healthy pregnancy compared to in a pregnant woman complicated with gestational diabetes. Other hormone secreted by adipocytes is leptin, with its levels are increased during gestational diabetes, and data show that is associated with increased size of fetus. Higher plasma leptin concentrations have been reported in also in individuals due to associated inflammation. So, what are the risk factors for gestational diabetes? Maternal genetic predisposition, having previously delivered a baby weighing more than 4 kilograms, being overweight or obese, having had gestational diabetes in a previous pregnancy, or polycystic ovary syndrome, or having an antecedent in family of diabetes. So long-term complications for the mother is type 2 diabetes, cardiovascular disease, obesity, ophthalmic disease, renal disease, or several malignancies. And short-term complications are preeclampsia and eclampsia, prolonged labor or dystocia, cesarean delivery, or surgical complications. Respect of the offspring, it is predisposed to be obese, to have endocrine morbidity or cardiovascular morbidity, or neurodevelopmental difficulties of ophthalmic diseases. And short-term complications is fetal macrosomia, shoulder dystocia, and asphyxia. So, what is macrosomia? Macrosomia is typically defined as birth weight above the 90% percentile for gestational age, or weighing more than 4 kilograms. Data shows that macrosomia affects 50 to 45% of newborns of women with gestational diabetes. The increased risk of macrosomia and gestational diabetes is mainly due to the increased insulin resistance of the mother. What are the literature data about macrosomia? It is shown that in gestational diabetes, higher amount of blood glucose passes through the placenta into the fetal circulations. So this excessive glucose level in the fetus leads to body fat storage, and which causes macrosomia, and also known to be large for gestational age. As I said, about 50 to 45% of babies born to diabetic mothers can have macrosomia, which is a threefold higher rate when compared to normal glycemic controls. Also, obese women had a double higher risk to develop macrosomia in pregnancy. How is a macrosomic child? Macrosomic child has a different pattern, a central deposition of subcutaneous fat in the abdominal and interscapular areas. They have larger shoulder and extremity circumferences, a decreased head to shoulder ratio, significantly higher body fat, and thicker upper extremity skin folds. So because fetal head size is not increased, but shoulder and abdominal size are markedly augmented, the risk of Erb's palsy, shoulder dystocia, brachial plexus trauma is more common. The pathophysiology of macrosomia, a short resume, is that the high maternal glucose and amino acids and lipids go through placenta to the fetus, increase the fetal insulin, which leads to macrosomia, and also the macrosomic child is predisposed to develop hypoglycemia. In the second trimester, the fetal pancreas, which is known to start to secrete insulin, start to respond to hypoglycemia and secrete autonomous insulin in response to glucose stimulation. So the combination of hyperinsulinemia, which is insulin known to be a major anabolic hormone, and hypoglycemia, glucose being another anabolic factor, leads to an increase in the fat and protein stores of the fetus, which leads to macrosomia. And I will continue with my study. Is a case control study which I conducted in the National Institute of Diabetes and Nutrition and Metabolic Diseases from Bucharest. The study started in 2018 and till November 2021. I included women aged with age 18 to 40 years at 24 to 32 weeks of gestation after they have the oral glucose tolerance test, which permit me to include them in the control group, a group with gestational diabetes with macrosomia and gestational diabetes with normal babies. My exclusion criteria were the age of mother below 18 or over 14, hypertension, preeclampsia, retinopathy, nephropathy, or psychiatric treatment. So in the control group, I had eight pregnant women. In gestational diabetes with normal offspring, I had 23 pregnant women, and gestational diabetes with complicated macrosomia, I had 5 pregnant women. So a total of 28 patients with gestational diabetes maintain normal glycemia only with the diet. And 4 of them needed insulin therapy. We recommended the nutrition recommendations by guides. They receive recommendations for to consume over 175 grams of carbohydrates, over 71 grams of proteins. And after also we recalled we have samples, blood samples. We collected blood samples where we isolated different biochemical and immunological testing. This is a diagram of my design. So I included pregnant women in the third trimester. I had a group control, gestational diabetes with normal offspring and gestational diabetes with macrosomic infants. I analyzed insulin, proinsulin, C-peptide, adiponectin, leptin level in these groups. And I continue to analyze insulin resistance, insulin sensitivity, and beta cell functions, and compare all of these groups. So, what were my results? Insulin levels decreased in gestational diabetes compared with those in control group. but a significant difference was only observed in the gestational diabetes with normal babies. Several studies previously reported contradictory results regarding the regulation trend of insulin secretion in gestational diabetes when defects in beta cell functions are present. My present study also analyzed the cholesterol levels. So we didn't find significant difference in HDL levels in the control group compared with the group with gestational diabetes. But we analyzed other studies and we didn't find association between HDL and macrosomia in gestational diabetes. Proinsulin levels in gestational babies has been previously documented, but where we find contradictory results. So in a present study, we registered a decreased in proinsulin levels in gestational diabetes with normal babies, but not in the gestational diabetes with macrosomic babies, and no insignificant difference in the proinsulin levels between gestational diabetes and healthy controls, could be found in previous studies, because studies did not divide the gestational diabetes group by baby birth weight. We also analyzed the group maternal weight gain, who were negatively correlated with parity and positively correlated with transaminases and childbirth weight. In the gestational diabetes with macrosomic babies, maternal weight gain presenting strong positive correlations with HOMA beta sensitive and pre-pregnancy body mass index, and negative correlation with adiponectin. Also, we find correlation between maternal weight gain and childbirth, but we didn't find correlation in gestational diabetes with normal babies, but a strong positive correlation between those two parameters and gestational diabetes with macrosomic babies. So, my conclusions is that my study adds to the current knowledge of the associations among factors involved in the physiology of gestational diabetes and macrosomia, highlights novel correlations that could aid future studies to elucidate the mechanism underlying this pathology, found different correlations of transaminases and lipid profiles with markers of insulin resistance or beta cell dysfunctions in both of the gestational diabetes group tested. And further studies are warranted to establish their involvement in the evolution to macrosomia in gestational diabetes. So my present analysis has drawn future directions to evaluate the relationship between high transaminases level or steatosis, hepatic steatosis, C-peptide, proinsulin levels, and transaminases in gestational diabetes, and the risk of macrosomia. Known that macrosomia lead to a vicious circles of diabetes, obesity, and metabolic syndrome. Thank you very much.
Thank you very much, Dr. Georgiana. We have a question. If you please open your camera so the audience can communicate. Please, if someone have the question.
And type 2 diabetes. For this, we will follow the following plan. After a brief introduction, we will present our clinical case, which we'll discuss before concluding. As you know, the World Health Organization defines pancreatic diabetes as other specific types of diabetes. It includes chronic pancreatitis, whatever the cause, pancreatic cancer, pancreatictomy, and pancreatic trauma, cystic fibrosis, and hemochromatosis. The prevalence of pancreatic diabetes and its consequences are underestimated due to misdiagnosis, which often classifies it as type 2. And in this presentation, we will report the case of a patient with pancreatic diabetes mistakenly treated as type 2 diabetes. It is a 61-year-old patient, a heavy smoker for 20 years, with no family history of diabetes. Diagnosis of diabetes was revealed by chance at the age of 59 and was considered as type 2 diabetes. He had been treated with OIDs with poor control despite triple anti-diabetes therapy, which led to a switch to insulin therapy. The patient also reported intermittent epigastric pain, which was considered ulcerative and treated with proton pump inhibitors. The evolution was marked by the progressive appearance of cholestatic jaundice in a context of a weight loss. Biological tests revealed significant cytolysis and cholestasis. Pancreatic MRI revealed a tumoral process of the head of the pancreas and calcifications in favor of chronic pancreatitis. Anatomopathological study showed an infiltrating adenocarcinoma against a background of chronic pancreatitis. This is the image of the MRI. Pancreatic diabetes is due to the loss of insulin-secreting beta cells. The loss is proportional to the degree of fibrosis of the exocrine pancreas. Conversely, other events delay the onset of diabetes, like loss of glucagon secretion and malabsorption due to loss of exocrine secretion, and the diabetes is often delayed. Unlike other types of diabetes, the islet loss involves not only the beta cells, but also the pancreatic polypeptide cells early in the disease course and the alpha cells late in the disease course. The physiopathological difference is reflected clinically. Ketoacidosis decompensation is rare, while hypoglycemia is more frequent, and glucagonemia is often low. Epidemiologically speaking, pancreatic diabetes accounts for 8% of all types of diabetes. Its etiologies are multiple, dominated by chronic pancreatitis, followed by neoplastic etiology, hemochromatosis, cystic fibrosis, and finally, pancreatectomy. Chronic calcified pancreatitis is characterized by fibrosis and progressive tissue atrophy. Calcifications will obstruct the lumen of the pancreatic duct, promoting pancreatic autodigestion, and ultimately extensive lesions lead to exocrine and then global endocrine insufficiency. Its diabetes is usually moderate, contemporaneous with evolving attacks of pancreatitis, then becomes permanent. Appears 1 to 12 years after onset of pancreatitis, but might be the first sign. With early insulin dependence, and the dominant clinical features is the great instability of diabetes due to malabsorption and glucagon deficiency. Hypoglycemia is frequent, severe, and unpredictable. It is the leading cause of the death. This diagnosis must be evoked in subjects aged over 14, malnourished, with a history of chronic alcoholism and a known history of pancreatic flare-ups. Pancreatic neoplasia is clinically manifest by abdominal epigastric pain, jaundice, pruritus, and sometimes fever and altered general condition, and occasionally diarrhea with steatory. Diabetes may be one of the relevant manifestations, often by DKA. Clinical examination find a large gallbladder, hepatomegaly, acids, and sometimes epigastric mass. The abdominal ultrasound or CT show a pancreatic tumor, biliary dilatation, or metastasis. Tumor markers may be elevated. The diagnosis is confirmed by tumor biopsy. Insulin resistance and pancreatic neoplasia may decrease after tumor removal and beta cells dysfunction. The pathophysiology is still poorly understood, but certain hypotheses have been put forward as destruction of Langerhans islets following pancreatic malignant infiltration. But what's against this hypothesis is that most pancreatic tumors are of the exocrine origin in the head. Another hypothesis suggests that the damage is due to obstruction of the pancreatic excretory duct, but these carbohydrate disorders are also found in tumors that do not invade the excretory ducts. Other factors are probably involved in the metabolic disorder, as increase in the secretion of amyloid, which is a diabetogenic factor, pro-inflammatory cytokines, and other tumor peptides released by cancer, which may contribute to insulin resistance. The diagnosis of pancreatic neoplasia must be evoked in the presence of recent diabetes in a subject over 15-year-old chronic smoker with no family history of diabetes, presenting with weight loss or unexplained inflammatory syndrome, or unstable, poorly controlled diabetes requiring immediate insulin therapy, or an old onset diabetes and a previously well-balanced diabetic who becomes unstable and requires insulin therapy. Another etiology is the cystic fibrosis. It is a multi-system disorder that results from deleterious genetic variants in the CFTR gene located on the chromosome 7, which encodes for the cystic fibrosis transmembrane conductance regulator protein. Defects in this protein lead to absence or multifunctional chloride channels in the apical membranes of the lung surface or glandular epithelium, resulting in the formation of thick and sticky mucus, leading to chronic lung infections, pancreatic and liver dysfunction, and reduced infertility. Clinical characteristics include progressive obstructive lung disease, sinusitis, exocrine pancreatic insufficiency, leading to malabsorption and malnutrition, liver and pancreatic dysfunction, and malinfertility. The CFF published consensus guidelines in 2017, establishing that a diagnosis of cystic fibrosis can be made if an individual has a clinical presentation consistent with the disease, a positive newborn screening, clinical feature consistent with cystic fibrosis, the presence of characteristic phenotypes such as of chronic, recurrent, sinus and pulmonary disease, nutritional and gastrointestinal abnormalities, urogenital abnormalities in male, like absence of the vas deferens and or salt depletion syndrome, or a positive family history of cystic fibrosis and evidence of cystic fibrosis, transmembrane regulator protein dysfunction. Its frequency is age dependent. Virtually, it is non-existent before age of 10, rare before age of 20, affecting 1/3 after age of 20 and the half by the age of 30. Cystic fibrosis transmembrane regulator protein plays a dual role in insulin or glucagon homeostasis. Abnormal intracellular accumulation of chloride in beta cells impairs their ability to depolarize in response to glucose. diminishing insulin release. In alpha cells, normal glucagon secretion is impaired by the inability of the cells to hyperpolarize in presence of high intracellular chlorine, resulting in uncontrolled secretion of glucagon by potentiating adenosine triphosphate sensitive potassium channels. The low bicarbonate to chloride transport ratio, which reduced secretory volume, creates a protein gradient at the lumen, resulting in obstruction and interstitial edema. Evidence suggests that over time, the resultant histopathological changes correlate with progression of the disease, damaging islet cells. Furthermore, CFRD patients have low level of gastric inhibitory polypeptide and glucagon-like peptide, which contributes to postprandial glycemic excursions and low secretion of insulin resistance and low secretion of insulin. Insulin resistance is associated with the fluctuant systemic inflammatory process associated with the counter-regulatory response of growth hormone, cortisol, and catecholamines that are released as a response to frequent pulmonary exacerbations and their treatment with steroid that these patients are typically exposed to. Another less frequent etiology is pancreatic resection. Diabetes pancreatic resections differs from type 1 diabetes mellitus, which is an autoimmune disease. It is characterized by an instability, low insulin dose, and a high tendency to ketoacidosis and hypoglycemia. Finally, and rarely, hemochromatosis, an hereditary autosomic recessive disease, causes diabetes in the half of its patients. In conclusion, pancreatic diabetes is often misdiagnosed as type 2 diabetes. It should be investigated in the presence of any unexplained diabetic imbalance or early signs of insulin deficiency or even minor digestive manifestations in any diabetic patient. And thank you for your attention.
Thank you very much, Dr. Ali. It was interesting and it was excellent presentation. Thank you for your presence and for your presentation. We'd like to take the question. You can open your camera.
For cardiovascular diseases, but we will make a Delphi procedure. Keywords is quality improvement, health balance scorecard, cardiovascular disease, Delphi procedure. Background: evaluation is a key to quality improvement. The adoption of tools such as health balance scorecard can help in the monitoring of the performance of the healthcare system or unit. Health balance scorecard is adjustable to the needs of every health unit and assists clinicians in goal setting, strategy implementation, and outcomes assessment. Certain clinical indicators are chosen for the evaluation unit. Until now, there have been 2 efforts of measuring 26 clinical indices for cardiovascular diseases at Health Center of Varis. Because of the difference in the way of measuring the clinical indices by two different groups, which was done in 2018 and 2021, by the two different groups, we performed the 2 measurements as immediate need for this procedure emerged. Because there was a different way of measuring these clinical indices, so there was emergency to do the procedure with my colleagues in order to agree in the way that we will measure these clinical indices, which I will show the following. In Greece has been established an institution of the personal doctor with a penalty in drug payments for those citizens who aren't registered to a personal doctor. Each personal doctor signs a contract with the health authority. The research question is what is the correct way for interpreting the context of the 26 clinical indices for cardiovascular diseases at Health Center of Varis? Since the two measurements found a difference in the way the text refers to its clinical indices, an attempt is made to reach agreement on the interpretation of the text between those who performed the first and second measurement. For the agreement to be achieved, there were constructed two tables. Table 7.5, which contains the 26 clinical indices, and table 7.5a, which sets out how to interpret the context of the 26 clinical indices for the prevention of cardiovascular diseases. In constructing table 7.5a, the context of the above mentioned contract of personal doctor was taken in consideration. Each personal doctor make a contract with the Minister of Health, and in this contract, one of the duties that is clearly written is that he has to fill in the electronic file of the patient. And this is very important for what I will say in the next. Now, here is the table 7.5, where we prescribe the context of the 26 clinical indices for the prevention of cardiovascular diseases. Here is the head bar scorecard. One style is strategic objective, performance index, index value. These index values result when we make the measure. When we measure this clinical index, we find a number, but the target index is 100%. And we started with table 1. With table 1 of clinical indices for cardiovascular diseases is investigations for risk factors of arteriosclerosis. So what we measure is number and percentage of patients who have been investigated for risk factors of arteriosclerosis. And this is shown by the file. If we want to measure the clinical indices that I will state, we must have files, electronic files. We must give time, part of our time, to fill in the files, the electronic files of our patients. So number one is clinical indices. Number one is number and percentage of patients who have been investigated for smoking. 2, for diabetes, for dyslipidemia, hypertension, BMI, family history of early angina. Table 2 is investigation for end organ damages. Number and percentage of patients have been investigated for organ damages. Left ventricular hypertrophy, leukomaturia, carotid arterial atherosclerosis, coronary heart disease, stroke, cardiac murmur, kidney damage, peripheral arteriosclerosis. Type 3 is interventions to reduce cardiovascular risk. Interventions to reduce cardiovascular in patients with blood pressure, diabetic 1 and 2, and dyslipidemia. How we define the indices, number and percentage of patients for whom we have done interventions to reduce smoking and to reduce BMI. The table 3, table 4 is prevention of complication, promotion of care in patients with diabetes 1 or type 1 or 2, and dyslipidemia. Number of patients in which lipid checks has been carried out every 12 months, in which microalbumin has been measured in the last 12 months, in which subject to endoscopy, which have been subject to endoscopy with mydriasis in the last 12 months, in which we have submitted to a recorded food examination in the last 12 months, in which we have submitted a recorded food examination for the last 12 months, in which we measure documented, recorded on the health card on their own, the capillary blood flows glucose in the last 12 months. That means that they have a diary with glucose measurement. And the last, to whom the HbA glycosylamin aspirin, HbA1c, shall be measured at least 6 months. And the last, achievement of target limit for blood pressure, HbA1c, number and percentage of patients with high cardiovascular risk with systolic blood pressure below 130, high risk with values of diastolic below 87, mid and low risk with prices of systolic blood pressure below 140, mid and low risk with price of diastolic blood pressure below 90, HbA1c below 8, high risk with values of low DL below 100, mid and low risk with prices of cholesterol below 250. Now the next table, we try to agree in the way that we will measure these clinical indices, but because we have said about the contact of family doctor, we will which contract ask from the personal doctor to fill in the records of the patient of his list of doctor list. We have two columns in electronic personal health record chapter to be completed. Clinical indices measured from the corresponding electronic personal record, electronic personal health record chapters listed in the adjacent column, and you will understand from what I will say. Now, electronic electronic personal health record chapter to be completed, which is the same, I repeat. The clinical indices of table 1 investigation for risk factors, which I have referred before in the previous tablet. The clinical 5 can be measured from diagrams. In this electronic file, there is a column which is diagrams. So if the doctor have fill in diagrams, he can measure clinical indices 5. If he cannot fill in the column of medical records with diagrams, he cannot fill in this clinical indices 5. Also, the clinical indices 6 can be measured if the family history part of the medical record is filled in. Clinical indices 5, 6 can be measured once the electronic personal health record has been completed at the part with the type diagrams. Now, in this way, we have made a proposal. What I propose to my colleagues this way of measuring. I don't want to take your time. In a similar way, all the clinical indices that I have said before, and there is I propose a way to measure the clinical indices. I don't want to your time is table 2 identification for target damage. Type 3, intervention for cardiovascular risk reduction. Type 4, prevention for complication, promotion of the care. Type 5, number and special days for patients who achieve the therapeutic goal. Results. The 26 clinical indices of table 7.5 are classified in 5 categories regarding the identification of risk factors and organ damage, preventive intervention, prevention of complication, promotion of the care, the achievement of target treatment. Table 7.5a contains 3 context agreements for category 1, 6 content agreements for category 2, 2 context agreements for category 3, 4 context agreements for category 4, and 2 context agreements for category 5. The context agreement of clinical indices were based on the above mentioned contract of personal doctors with the government. For the total 15 questions asked from the 8 participants of our study, there was a strongly agree answer for all the participants for all the 15 questions asked. Thank you very much for your attention.
Thank you very much, Michael. Thank you. Thank you very much for your presence and for your time for true presentation. I'm audible. Are you listening? Can you listen me?
Yes, I can listen to you. Yes.
Okay.
Cannabinoid system through the melatonin cannabinoid type 1 receptors heteromers. Donc first, melatonin is a neurohormone that is synthesized in a circadian way by the pineal gland, and it has many functions. And one is to reset the peripheral clock that are within the organs inside. It is involved in the sleep cycles, in neuroprotection, and also in glucose homeostasis. Melatonin acts through two membrane receptors that are called MT1 and MT2. The two receptors belongs to the superfamily of G-coupled receptors. Both receptors are coupled to the heteroprotein GI that, when it is activated, is going to reduce the intracellular level of cyclic AMP. For cannabinoids, you have three types of cannabinoids. The first type is the one that are synthesized by the body, and the two main cannabinoids are anandamide and 2-arachidinoyl glycerol. And as you can see, they are derived from fatty acid. And also you have phytocannabinoids, as delta-9 tetrahydrocannabinol that is found in cannabis when people are smoking. And this is the molecules that are responsible of the psychoactive effects. And you have also synthetic cannabinoids. Also cannabinoids have many functions. It is involved in synaptic plasticity, in a reward system. It is also involved in sleep induction and in neuroprotection. Like melatonin, cannabinoids act through two membrane receptors that are called CB1 and CB2. And also these receptors are coupled to the GI that is going to reduce the intracellular concentration of cyclic AMP. Here, I will show you cerebellum as a model that we use because it was known that cerebellum expressed a high level of the cannabinoid type 1 receptors. Here you have an in situ hybridization assay where the mRNA is detected. At the right, you have a labeling of the melatonin site with radio label melatonin. And you can see also that many melatonin binding sites are found in cerebellum. Previously, until the end of the 20th century, membrane receptors were thought to act at the plasma membrane. Here is the plasma membrane. Here, the GPCR with the heterotrimeric G protein. And when the ligand or the hormone is binding to the GPCR, it will activate the receptor and it will activate the signalization pathway. But since it has been found that you can find now functional GPCR in intracellular subcompartment, like the Golgi, the endoplasmic reticulum, and the mitochondria. And all of these receptors are functional. At the beginning of the years 2000, it has been shown for the CB1 that CB1 was found at the outer mitochondrial membrane of the mitochondria. Here you have an electronic image where you can see, here is the mitochondria that is cut transversally, and you can find signals for CB1 at the outer mitochondrial membrane. The same was found later in 2017 for MT1. Here, this is a mitochondria from a neuroblastoma cell line that is called Neuro2A. And again, labeling was found at the outer mitochondrial membrane and not inside the mitochondria. For both receptors, they were found to be functional. Here, using purified mitochondria from brain, from mouse brain, it has been shown that you can incubation with the cannabinoid ligand will induce a decrease of the mitochondrial respiration, and this decrease is specifically dependent, is specifically done by the CB1 receptors, because the mouse, CB1 knockout, donc mouse that does not express CB1, does not inhibit anymore, ça s'appelle ça the mitochondrial respiration. Mitochondrial respiration is linked to the ATP production. The same was done with transfected cells for the MT1. For the MT1, here there is a decrease of mitochondrial respiration when purified mitochondria were expressed MT1, and nothing was found when cells were transfected with MT2, donc with receptor 2. Donc there was a MT1 dependent effect on mitochondrial respiration. The GPCR, donc the membrane receptor belonging to the GPCR superfamily, has a capacity to heterodimerize for some. Here are some examples for melatonin receptors and cannabinoid receptors. I will not go into details. I will just pinpoint one example. Here, the melatonin type 2 receptor has been shown to heterodimerize with the serotonin receptor type 2C. And this receptor has been found in vivo to act in the central nervous system. And for the cannabinoid receptor, many has been found. And for example, here, the CB1 has been found to be heterodimerizing with the dopamine D2 receptor. And again, there are proof in vivo showing that this heteromers is functional in a mouse brain. We asked, 5 years ago, we asked a question: is it possible that for MT1 and CB1 to heterodimerize? And second, are these heteromers found at the plasma membrane and at the mitochondrial level? To show that MT1 and CB1 in fact may heterodimerize, we use several techniques that I will show you. First, donc this is an immunofluorescence experiment, and you have here confocal image taken with a microscope. Cells were transfected. It means that it transiently expressing MT1 and CB1 together, and the two receptors were labeled with an primary antibody against a tag that is located at the N-terminus of the MT1 or the CB1 receptor. Here in red, you have the staining of the MT1. In green, the staining of the CB1 in HEC cells. This is a usual cell model for pharmacologists. And here you have a merge of the two images. And the yellowish picture shows that, in fact, the distribution of CB1 and MT1 is similar. And this is another example done this time in a neuroblastoma cell line, that is the neuro2A cells. And again, you can see yellowish picture. Donc there is a high level of co-distribution of the two receptors inside cells. After we perform co-immunoprecipitation experiment. Alors, co-immunoprecipitation experiment, what is it? We co-express the two receptors inside a cell model. Here it's HEC293 cells. And we pull down one receptor with using either anti-flag antibody or an anti-MT1 antibody. We pull down that and we hope that the CB1 would interact with MT1 and would be found after immunodetection using an anti-CB1 antibody. Now, these things are done with a Western blot experiment. It's experiment where proteins are run into a SDH spage gel. Donc, proteins are separated according to their molecular weight in an electrical field. Here in red, you have, in fact, the result of the immunoprecipitation. Donc here, there was an immunoprecipitation anti-MT1, and we revealed with anti-HA that, in fact, is a tag linked to the CB1. We can find that we found the 70 kilodalton CB1 band, meaning that CB1 is interacting with MT1, and also we found a 110 kilodalton band, and we demonstrate that, in fact, this 110 kilodalton was the heteromer MT1 CB1, because it also hybridized with an anti-MT1. To demonstrate that MT1 and CB1 may heterodimer, you need more techniques. Donc here are results obtained with an in vivo experiment. Donc we prepare a protein extract from mouse cerebellum, from mouse of what we call wild type, meaning that they express MT1 and CB1, or mouse from MT1 knockout mice, they do not express MT1, and this one, CB1 knockout, they do not express CB1. And we did this immunoprecipitation experiment using an anti-MT1 antibody, and after we tried to reveal the presence of CB1 with an anti-CB1. Here with the wild type, you can see that we found the CB1 signal here at 50 kilodalton here. In fact, there are a series of bands here, and this series of bands is lost in the CB1 knockout mouse. You have nothing more. In fact, this CB1 MT1 heteromer exists in mouse cerebellum. And it's not only a product of an overexpression in transiently transfected cells. Here we use another techniques also to demonstrate the heterodimerization of MT1 and CB1. This technique is called proximity ligation assay, or PLA reactions. For this, we use again primary antibodies against the tag, against CB1 or MT1, and we use secondary antibodies that have nucleic acid link to it. And these nucleic acids for both are complementary. If the two secondaries are close enough at a distance below 40 nanometers, the two nucleic acid can be together because of the Watson-Crick bonds. And after, you have a PCR reaction that is going to develop, and you have a labeling that is going to stay at the level of the reaction here. And here you have an example here. So this is HEX cells and Neuro2A cells. Here, the two cells do not express CB1 or MT1, but they were subjected to this PLA experiment. You observe no signals, you just observe the nuclei that are labeled with DAPI. And here, when cells are co-expressing MT1 and CB1, you can observe the dotted immunofluorescence signal, meaning that MT1 and CB1 are close enough at a distance below 40 nanometers in these cells. We did also that here in this experiment. We can see that there are MT1-CB1 heteromers inside the cells because cells were permeabilized. And if we do not use permeabilized cells, donc we are just looking the presence of MT1 and CB1 heteromer at the cell surface, meaning that the MT1 CB1 are also present at the plasma membrane. Here we perform also electronic microscopy experiment in hex cells co-expressing CB1 and MT1. And here the principle you have is indicated at your right. Donc again, we are using antibody against MT1 or CB1. And this time, the secondary antibody are linked to gold particles of different size that we can differentiate for the two receptors. We have gold particles of 6 nanometers and gold particles of 15 nanometers. Here, donc, this is a picture of the plasma membrane. You have here the intracellular part of the cells that is full of ribosomes. Here, the outside of the cells, and here you have examples of MT1-CB1 heteromers. Here you have two 15 nanometers gold particles corresponding to 2 CB1 receptors and 3 6 nanometers corresponding to 3 MT1 receptors. The stoichiometry of the heteromers is a question that is difficult to ask because in literature, people have described stoichiometry of 1-to-1 or 2-to-2. Donc, at this point, we have not done the appropriate experiments to know the exact stoichiometry of the receptor of MT1 and CB1 in the heteromers. We use also to demonstrate the heteromerization of MT1 and CB1 a tool that is a very specific tool that is called a cell penetrating and interfering peptide. Now, what is it? This is small oligopeptide that are synthesized by a machine, and at the N terminus is added the sequence of the HIV virus that enables the peptides to go into the plasma membrane. Here, donc, the sequence of the HIV was linked to the transmembrane region 5 or 6 of CB1. Our transmembrane region is this region here that are embedded into the plasma membrane. What happens when you incubate cells with this, cells co-expressing, in this case, CB1 and serotonin receptor that are known to form heteromers? When you incubate with high concentration of these interfering peptides, the interfering peptide will go into the plasma membrane and will compete for the interface of dimerization and will provoke a dissociation of the heteromers. Here, just I have to introduce you this technique. This is complementation technique. This complementation technique, this is a way to show that two proteins are close enough. It's based, donc you have here an enzyme that is called nanoluciferase that is divided in two parts. One part is linked to the protein A, this is genetic engineering, and the other part is linked to the protein B. Donc here it's MT1 and here it's CB1. If MT1 and CB1 will interact, the two parts will be close enough to complement each other and to reconstitute the nanoluciferase activity. And this is also, and here, this is a little bit, this is what is called a energy transfer. this is donc here when the nanoluciferase is reconstituted, it can emit energy, and if there is a third partner, protein is not, it could be C, we'll see in the next slide, the energy could go from the nanoluciferase to the YFP, and this transfer of energy can be detected with a special machine. Donc, here, donc, this is experiments, complementation experiments done with CB1 and MT1. Donc, the two receptors were expressed in 2 and 3 cells, and the nanoluciferase activity was measured in presence or absence of the interfering peptide. Here, this is the luminescence, donc this is the basal activity of the nanoluciferase in absence of interfering peptides. And when we co-incubate with the interfering peptide corresponding to the transmembrane 5, we obtain a decrease of the luminescence signals, meaning that part of the MT1 CB1 heteromers were dissociated. This decrease was not observed for the TM6 or TM7, meaning that these two TM6 and TM7 are not involved in the dimerization interface between CB1 and MT1. Here we measure the internalization of the MT1 CB1 heteromers. For this, we used the same technique of complementation as I showed you in the previous slides, and we coupled that with a biomarker of the plasma membrane. Here, the biomarker is GAP43, a protein that is known to be distributed at the plasma membrane. To this GAP43, we have linked also an energy acceptor that is called YFP. And we are measuring, in fact, the energy transfer between the reconstituted nanoluciferase and the YFP. Donc here, donc the cells are co-expressing the two receptors. Donc here they are incubated with saline, just it's our control. Here they are incubated with an inhibitor of the melatonin receptors. Nothing happens. Here, cells are incubated with 10-8 molar melatonin. We observe a decrease of the cell signals, meaning that, in fact, the heteromers is internalized because it cannot interact anymore with the GAP43 YFP that is at the plasma membrane. When we co-incubate with melatonin and the melatonin inhibitors, we restore partly the signals, meaning that this decrease is dependent of MT1 receptor, and here it's the same, but with a concentration of melatonin of 10-9. Donc there is a melatonin 1 dependent internalization of the MT1 CB1 heteromer. Furthermore, we try to evaluate the intracellular compartments where the MT1 CB1 heteromers is trafficking after internalization. It's in the same approach. Here, donc, the heteromer and the complementation with nanoluciferase, and here we have biomarker of the early endosome, and the biomarker is RAP5 coupled to YFP, and we have a biomarker of the late endosome that is RAP7. Donc these things are well characterized in the literatures. What happens with the signal? Here when the cells are incubated with the inhibitor of melatonin receptor, nothing happens. When it is incubated with -8 melatonin, we have an increase of RAF5 and an increase of RAF7. It means that the heteromers are going from the plasma membrane to the early endosome and after to the late endosome. And again, this is the demonstration that this process, what we call in cell biology trafficking, is MT1 receptor dependent. In my first slide, I had introduced the point that MT1 and CB1 receptor were described to be associated to the outer mitochondrial membrane. Here, we wonder if the MT1, CB1 heteromers were associated with the mitochondrial network. And we use this proximity ligation assay experiment coupled to an immunofluorescence experiment. Here, it's more clear here, the mitochondrial network was labeled with a protein that is called TOM20. And this protein is known to be located at the outer mitochondrial membrane. Here, this is, on appelle ça donc PLA experiment. Here we can, with the dotted staining, and in fact, using confocal microscopy, we can see that the PLA dotted staining, in fact, is also co-distributed with the mitochondrial staining, meaning that the MT1, there is a pool of MT1 CB1 heteromer that is closely associated with the mitochondrial network. We wonder to know if this pool of MT1 CB1 heteromers were associated with the mitochondrial, were functional. For this, we perform mitochondrial respiration using purified mitochondria. Either purified mitochondria from transfected cells or from mouse cerebellum. Here, we worked at sub-level concentration of ligands. When we use, for example, here, WIN, that is a cannabinoid agonist at 100 nanomolar, we did not get any inhibition. But we got an inhibition at a concentration of 1 micromolar. With melatonin, at 100 nanomolar, we got no inhibition. We got an inhibition of approximately 20% at 1 micromolar. But when we combine the two ligands at a suboptimal concentration of 100 nanomolar, we got an inhibitory synergistic effect of 20%, meaning that the two receptors are, in a way, co-interacting to give an inhibition of mitochondrial respiration. The same was obtained with the mouse cerebellum at a concentration that is lower again. 10 nanomolar WIN gave nothing. 100 nanomolar gave some 20% reduction. The same for 10 nanomolar melatonin. Melatonin at 100 nanomolar gave a 20% reduction, and the combination gave a statistical inhibitory action. Donc, in fact, it seems that the MT1 CB1 receptors, first, that the CB1 MT1 receptors exist, and they can act locally at the mitochondria to inhibit mitochondrial respiration. Donc, here are the main results of these last 5 years. Donc, MT1 and CB1 receptor heteromerize. They are detected in the mouse cerebellum. The heteromers are found intracellularly and at the cell surface. which have a huge implication for the signaling pathways. We found also that the intracellular heteromers are linked to the mitochondrial network, and that activation of both receptors gave a synergistic inhibition of mitochondrial respiration. Donc, all this work requires the collaboration of teams that I have highlighted here, mine, and also from different teams of France and Spain. It's open for discussion.
Thank you, sir. Thank you very
Yes.
much. It was super interesting for me because I work on receptor, on expression, particularly through biocore technology and confocal microscopy. So it was very interesting for me.